exciting to be here, actually, and so many people, and they've asked the men as well, which is really important. So thank you for those men as well, and thank you for coming. It's a real delight to be here today. As you might know, we work very closely with Claire and Portland Hospital, and we've got some clinical space here as well, and any excuse to come to London is great. So before I start, just to let you know, I don't have any financial disclosures. Myself or no one who works in our organisation do any paid work with any pharmaceutical companies, and every day I get asked to be a name behind, a face behind, a quote behind some ridiculous menopause product, and I'm not. I don't have any declarations. I'm not going to read out on there, but I sort of spend all my life thinking about hormones, actually, not just the menopause. It's extended to, it was the menopause, then it was the perimenopause, and now it's hormones, actually. And it's really important because the work I'm doing is affecting 51% of the population directly and 49% indirectly. But if we think about testosterone deficiency in men, which is about 30% of men, it's probably the majority of people worldwide who need some of the work that we're doing. My real declaration is that I take HRT. And if I didn't take it, I wouldn't be standing here today. I certainly wouldn't be happily married. My children probably wouldn't enjoy having a mother, and I know absolutely for certain I wouldn't be working as a doctor. But it's important, actually, because I really struggled to get the right dose and type of HRT. And I'm a white middle-class English-speaking woman who's very well educated. And if it was a struggle for me, then it's a struggle for lots of other people. And a lot of the work we do in the organisation is not just about seeing our patients, but it's about lots of outreach work, constantly thinking about communities and people who are never going to get our expert help and advice. So this is where I've come from, the centre of England, or nearly, Stratford-upon-Avon, nowhere near the coast, which is a bit annoying when the sun is shining. We all know it for Shakespeare, but we're trying to knock Shakespeare off his perch and make it the menopause capital of the world. So it's a nice place to work, but I don't just run the clinic. In the clinic we have over 100 clinicians that work with us. We see around 4,000 women a month through the clinic, a lot of virtual consultations, but increasingly face-to-face. But 3 years ago, I set up Balance, which is a free app, and it's always going to be free. And we've had over 1 million downloads of that, so in many countries. And actually, we found out today it's been shortlisted for an award, an Impact Award by Apple. So I'm very proud of the team for that. It's been App of the Day a couple of times and Editor's Choice once. But it shows the demand of what's needed for what we do. So I'm talking about hormones and well-being. I'm sure you all know what hormones are, but they are just chemical messengers. They are the most important things we have. They tell our bodies how to function. They're messengers that go in our bloodstream and go from one cell to another. And we need them. There's lots and lots of hormones that are in our body. And I'm not going to list them all. But we're talking about our sex hormones today. So hormones that are produced from our ovaries and also other areas. There's a few flyers that I put out. This is very basic. I'm not going to read it out. But estrogen is a really important hormone. It's a female hormone, but men actually do have some estrogen as well. And every single cell in our body responds to estrogen, whether it's in our brain or our lungs or our heart or our bladder or our muscles. Every single cell responds to estrogen. And also progesterone, another important hormone, which often is spoken about to protect the lining of the womb as part of HRT. But it's also produced by our brains. It's very anti-inflammatory. It's a very important hormone. And then testosterone isn't just for the boys. Women produce testosterone too. And in fact, when we're younger, we produce more testosterone than estrogen, and our levels decline with age. So you could argue, and I certainly can argue, it's probably one of our most important hormones in our body. But then what about well-being? I went to a Department of Health meeting many years ago when Dame Sally Davis was the CMO, and she said, I don't like the term well-being, it should be wellness. It doesn't really matter what it is, but if you look up well-being, it's how an individual feels about their life, how happy they are. Quite hard to quantify, isn't it? Quite hard to do an RCT, seeing if something improves our well-being or not. But actually, if we're happy and we're surrounded by happy people, then we are going to be more happy. And it's not a bad thing, being happy. So this isn't it is a sort of happy story, but not completely. This is one of my patients, Lindsay. She's given full consent to talk about her, and I did a podcast with her recently as well. So she's 44-year-old, and she was completely fit and well, and she had no past medical or psychiatric history at all. She had 2 children who she completely adored. Her husband here is a GP as well down in Portsmouth, and she explained for about 2 years her periods had started changing. And she had this overwhelming anxiety, really worried about things. And so she went to her GP and they said, well, it's probably depression and anxiety, we'll give you some antidepressants. So she took them because she didn't know what else to do. Didn't help, so she went back and had some others, and then went back a 3rd time and still was given some more antidepressants, which didn't help. So she was referred to a local mental health team, and 8 weeks later, she then said things that really escalated. She got really severe palpitations, and she had some very intrusive, very dark thoughts about harming herself. She really didn't want to be here anymore. And she was sectioned under the Mental Health Act, and that's a big thing to do, especially her husband was trying to avoid it, but they were very worried about her harming herself. She was then given 9 rounds of electroconvulsive therapy, and she was diagnosed with bipolar depression. She then went on weekend leave. After 6 weeks, she was no better, so she managed to persuade them to let her go out. And she then jumped out of a building. She wanted to kill herself. She thought there was no point living. And fortunately for her, actually, she caught on some scaffolding, and it meant that she cushioned her fall with the scaffolding, and she got away with a fractured back, pelvis, ankle, and went to a trauma hospital. And she was there for 6 weeks. But she said that was the worst of everything. My brain had gone and my body had gone. And her husband was saying, I just didn't know what to do. How could she get out? How could I look after her? So I just wanted to show you if it works.
I was like a completely different version of myself. My thought processes, I felt the scariest symptom for me was I couldn't feel any love for anyone, not my children, my husband, my parents. I'm such a big animal lover. I couldn't bear my pets near me. It was such the complete opposite of who I am. So that's the person who got admitted. And I just felt just desperate that this was a new version of me, and I couldn't work out why. And it did feel, and I did say over and over, this feels so biochemically. It doesn't feel, there's nothing that's happened in my life. My life is in such a good place that I knew that there was no trigger event, no trauma.
So her well-being, you must admit, wasn't great at that time. And I'll come back to her at the end. Of course, you know what her diagnosis is. I'm not here to talk about hormones and not think about her hormones. She was a 44-year-old perimenopausal woman. And we see and hear stories like this every single day. I did a consultation this morning in somebody who's in a psychiatric hospital who's just started on lithium. She's also on quetiapine, and they're talking about ECT. She's had postnatal depression. She's had PMDD. She's 47 and her periods have changed. No one's spoken to her about hormones. So it's real, it happens all the time, and I'm sorry that I've started with such a negative part of the presentation, but it's important to think about why well-being is so important with hormones. So thinking about what the menopause is, it's been defined for many years about our periods, about our reproductive life. And actually, it is more than that. I don't want to be defined as a 53-year-old woman as someone about whether I have periods or not, or whether I can be fertile or not. And actually, for many women, about 3 in 100, more in some areas and communities, under the age of 40. My youngest patient was 14 when she was menopausal, so no one's too young actually. And the perimenopause is the time before when hormones are fluctuating. But once people are menopausal, they're there forever. There's always going to have low hormones. So we need to think about the hormones and this deficiency that's occurring in our body. And this is a great quote by a neuroscientist, Louise Newson, who some of you might have heard of, and I'm doing quite a lot of work with her, and her new book's coming out soon. But menopause affects the brain as much as it affects the ovaries. And I'm sorry to the gynecologists in the room, I'm not actually very interested in ovaries. I'm interested in our brains. And this is a quote I found from 1851. We've known about menopause for many years. A lady aged 53, and she describes heaviness of the head, giddiness, and some flushes of heat, and drenching perspirations. And she consulted several medical men. Thought I would just add that in. Isn't that interesting? And they bled her, actually. They ordered 8 ounces of blood to be withdrawn because they thought periods will cure things because women traditionally got better when they had periods. How wrong they were, but how right they were, describing something going on in our heads. And these are the top symptoms that we found from the Balance app. And if you see brain fog, anxiety, low libido, memory problems, low mood, hot flushes and sweats are there, but they're not the things that are affecting people the most. This is a great picture that Dan Riesel, who's our research lead, who's in the audience, has kindly loaned to me. It's not his brain and it's not mine, but it's somebody's brain that's been sliced. And this is where estrogen and testosterone work in various areas of our brain. And all these areas are really important. They determine how we work with our personality, how we think, how we remember, how we move our body as well. Our brain is really important, clearly, for everything that we do, even the way that our breathing is, or the heart rate, the way everything happens, and it's all there. And you can see with hormones, our brains do light up, which is really important. But our hormones, estrogen, progesterone, and testosterone, work as neurotransmitters, but they affect other neurotransmitters. So this is only 3 that I picked out. I could have picked out any. But thinking about well-being, and you'll see in the middle, we've got the cognition, emotion, mood. So serotonin, our happy hormone, noradrenaline gives us our energy and alertness and our get up and go, and dopamine is our reward hormone. But all 3 of them really help with our well-being. But guess what? Estrogen, progesterone, and testosterone all increase their levels. So when our levels of hormones are low in the menopause, all these neurotransmitters reduce. We've just done a survey of addictions during the menopause, and they really do increase because people are wanting some sort of reward. If they're not getting it on their own endorphins and their own hormones, then they'll look elsewhere. I'm not going to talk through this slide, you'll be pleased to know. But actually, estrogen has 2 effects on the brain, really. It affects the genomic effects, which means it changes our genetic makeup, which is really important. And then it has these quick-fire effects. So anything, when a receptor goes onto the cell membrane, which is this squiggly bit at the top, all these different chemical processes occur. And when they occur, it can affect, and in our brain, it affects the way our brain works and functions and repairs itself, which is really important when we think about keeping a healthy brain, which is what we all want as much as possible. Lisa Mosconi did these great pictures, and this is the brain lighting up before and after the menopause, and the white is lit up, thinking, working, the metabolism of the brain is there. And after the menopause, this is someone clearly without hormones, it's different, and that's no surprise, we know that, and this is her new book that's coming out soon. But these are the symptoms that worry me the most, keep me awake at night, are the psychological symptoms, because these are having a big impact in menopausal women, not just in the UK, but worldwide. There's only 1.2 billion of us worldwide that need listening to. And these are quotes that we hear all the time. People saying, I've lost myself, I don't like who I have become, I can't live like this anymore. And we know depression increases, and it increases in the late 40s. Of course, it's not going to be all due to hormones, but it will. And Claire Crockett, who's in the audience, and a psychiatrist from Oxford we work closely with, Sophie, has written a paper that came out a few days ago, which is really talking a lot about mental health and hormones. And there's a 16-fold increase in depression in women in this age, and a 7-fold increase in suicide, and we're funding a PhD in suicide prevention, and some of our preliminary data is really revealing, but incredibly sad as well. So it's quite doom and gloom, my presentation, but it's going to get worse before it gets better. There are risks to health with our menopause. I'm not a gynaecologist, and I'm a physician and a clinician and a GP, but I don't want people to come and see me. We want to prevent disease. And also, it's very poignant when we're here with Longevity Week, thinking about how we can reduce diseases. But there is increased risk, whether we like it or not. Our hormones, they're biologically active, they have important roles in our body, and without them, there's an increased risk of osteoporosis that affects 1 in 2 women. After an osteoporotic hip fracture, mortality rate is 20% after a year. One of my good friends recently was diagnosed with a very early stage breast cancer, and I've supported her, and she'll be fine. She's had a curative operation. And I said to her, if you'd told me that you'd had an osteoporotic hip fracture, I would be more worried. And it doesn't have the same resonance, does it? But actually the mortality is far higher. Heart disease kills most women globally. So heart disease increases with the menopause. Type 2 diabetes, because it's metabolic processes that are changing. And obesity. We know obesity has now overtaken smoking as #1 risk factor for cancer. cognitive decline in dementia. We're all scared of dementia. We want our brains to work. The longer a woman is without her hormones, this is fact, I'm afraid, the greater the risk of dementia. I've already said depression, kidney disease as well, and different cancers. And an earlier death. It is quite doom and gloom for menopausal women. And this is really important. This is from the Department of Health, looking at the 6 most common diseases that are having the biggest impact on mortality. Cancer, dementia, musculoskeletal disorders, mental health, cardiovascular disease, they're all related to the menopause, whereas hormones are never thought about at all. And if we think about longevity, we're thinking about how long we could be healthy for. It's not the age we die, it's the journey to that age, which is so important. And this is the top is from women from the least deprived area in England to the most deprived. So the average age you are when you're still healthy in the most deprived area, is 51.4. It's 71.2 in the least deprived. So that's a 20-year difference. So if I'm living in an inner city council estate compared to a nice affluent leafy suburb, then I'm going to be healthy for 20 years longer. And we're thinking about the impact we can have in longevity. We have to think big. We don't think about ourselves as our nice white middle class people. We have to think about these poor people who are having awful life. And so I'm very interested in this term, inflammaging, some of you might have heard. And it's basically more inflammation as we age. Why does our body change? Why does it suddenly increase the risk of diseases? What happens in the aging process? And we know there's more inflammatory diseases. Again, I'm not going to talk about this in great detail, but we have our immune system protects us. It protects us from infection, but it protects us from disease as well. And without disease, our mitochondria, which is our powerhouse in our cells, don't work properly. All our cells work, and even this autophagy, where our cells basically eat each other because they're just not got any signals to tell us that we need to stay healthy. And all of this is determined by our hormones, but it's been forgotten for so many years because our hormones have been defined by periods and about fertility. And what a surprise, actually. This is similar to exactly the same diseases as I showed you before, but these are the diseases associated with inflammaging. This is a busy slide, but inflammation increases all these diseases, including, if you look, and I know the font is small, but Parkinson's, Alzheimer's, heart failure, fatty liver disease, asthma, bronchitis, cancers, multiple sclerosis, they're all due to inflammation. It's not just the 6 diseases. And sex hormones are really important for this. And this is just science. It's basic science, but it's been forgotten for far too long. So I am going to make the last little bit a bit happier, because are there effective treatments? Well, yes, there are. We've known about them for absolutely decades, but we've been ignoring them. And I was looking actually at these adverts that from the 50s, and this is about, in the menopause, transition without tears, because women get emotional and we don't want women to cry, especially at a nice drinks party with our husband. So this is Melprene, which is like a sort of amphetamine-based medication, but that's quite good to calm us down. I'm sorry this is out of focus, I couldn't get a better one. In the severe depressions of the menopause, marked by apathy and psychomotor retardation, well, let's give them another, this is Benzedrine. Not a nice drug really, but we could give it as either tablets or elixir, so it could just gently go down our throats and we can just carry on arranging the flowers for our husband. Or we could just have sweet, refreshing Valium. That would just sort us out. When denial is the best alternative. Many of us who have been menopausal or perimenopausal do want to be in denial. But actually this isn't great, is it? It's not really medicine, it's not treating the underlying cause. But actually Lindsay was given modern equivalents of these. So nothing has really changed over 50 years. But then we think about the men. He's suffering from estrogen deficiency, and she is the reason why. But this was Premarin, so this is HRT. And they're right. And I showed this to my husband last night. You don't really want to know what he said, but he did feel quite sorry for the man. But then what about let's help keep her this way, Premarin? Now, this is really interesting because Paul, my husband, saw it and said, well, that's what you're doing in the clinic, isn't it? You're keeping women happy. And so she's got good well-being. I'm not quite so sure about his look and how it works. But actually, is it bad that we're keeping people happy, enabling people to be happy? And women do outlive their ovaries. And for this woman, it was really difficult because it was about her husband in the peak of his career. But actually, it's in the peak of our careers that it happens, and that's what we have to think about. So there are lots of treatments. Aren't we lucky? We can have face creams, we can have shampoos, we can have supplements. In fact, $120 billion a year is spent on this treatment. So it's great, but it's not evidence-based, actually. And it's very expensive, and it's not going to reach areas of deprivation. We do have HRT. It's only 3 letters. It's just natural hormones. And it treats the underlying cause. Isn't that great in medicine if we can do that? It's not a one-size-fits-all. It's very individualised, the type and the dose. And that's very, very important. And that dose and type can change with time as well. So we're lucky we have all this. A lot of it is available on the NHS. It's dirt cheap, so Big Pharma aren't that really very interested in it. But we've known for a long time the sense of well-being does improve with Premarin. This is the conjugated equine estrogens, the pregnant horse's urine. But it really will improve menopausal symptoms. And it says, in addition, it gives the patient a feeling of well-being. Now, people have been really rude and quite vocal about how terrible these adverts are. But I actually don't think it's bad as a doctor if I make people feel a bit happier. And it's no different. These are comments that I see when I see people in the clinic, and I got a notebook, but it's so full of horrendous stories, I try not to open it. But I'm a shadow of myself. I want to lock myself away. I'm in a spiral of self-doubt. I'm holding on by a thread. I'm existing rather than living. I just want my life back. And I'm giving them not Premarin, because the HRT we prescribe now is derived from yam plants. It's very natural, but things are in focus. Taking HRT is the best thing I've done. I'm not stuck in a fog. I mean, even the bottom right one, I can clean the house. Not always a bad thing, but you know, it is important that we're not neglecting society, neglecting women. And there are more benefits of HRT. It's not just about well-being, actually. We know the benefits outweigh any risks. But look, guess what? It reduces the risk of all those inflammatory diseases, all the diseases associated with the menopause. It's not rocket science. My 12-year-old could give this lecture. It's really not difficult. The difficulty is that women being allowed to access evidence-based treatment, because we know in the UK it's only 14%. You'd think there's so much going on in the media, most women would get it. But the majority of women are not able to get it. Antidepressant prescribing is a lot easier, and it's a lot easier to access antidepressants than HRT. And in areas of deprivation, it's as low as 2%. So this is just a study from Lisa McConey's work, the photo I showed earlier. Really important, actually. It's a good study. They looked at a big sample size. Estrogen was associated with a 32% risk reduction in dementia risk. And if it's combined with a progesterone, some of it was the synthetic one, so that's why the data is a bit skewed, but it was still a 23% reduction in dementia risk. Was this in the headlines? No, of course not. Why would you want to have a good news story to women? But it makes sense as well, the way estrogen works. And some of her work she's bringing out is going to be more transformational. But she's being listened to because she's a neuroscientist, not a GP. So it's good. It's good to work with other people as well. Just before I end, about testosterone, I've already said it's a really important hormone, and we know that symptoms such as muscle loss and sarcopenia, also memory loss, insomnia, muscle and joint pains, fatigue, can be very common with testosterone deficiency. It's all been about reduced libido, but if you look up Freud's definition of libido, it's not just sex, it's joy of life as well, and I would have thought it does really include well-being too. This is some work that Dan and Amy, who's here as well in the audience, who have been slogging their guts out literally to do. Looking at when we give testosterone for women who have reduced libido, we notice that, yes, their libido improves, but actually 73% of people find that their loss of interest in most things improves. Their feeling low or depressed improves. Their anxiety, their irritability improves. No surprise when you think of that brain picture and how testosterone works. So it is a really important hormone, and a lot of people, like Lindsay at the beginning, estrogen can help, but testosterone makes the biggest difference. So just finally, I want to end on some good news. Lindsay was given HRT. Her husband had to eventually prescribe it for her because the trauma hospital said, no, we don't prescribe HRT. They'd given her morphine, they'd given her all sorts of horrible drugs, but they weren't giving her HRT, so he had to get it for her. And most of her symptoms, unsurprisingly, have completely improved. I am enjoying my life life again and feel happy. And, you know, we shouldn't be denying obvious things in medicine. So quite a lot of information, hopefully left on a slightly more positive note than the beginning. So thank you very much. We've got 5 minutes for questions, so I'm happy for anything to be thrown at me. The more controversial, the better.
Can I? It's me. Yes, it's me. Yeah. Can I ask you? I am quite anti-taking anything, and I've been thinking about HRT for a while. I think because the symptoms are maybe slightly more worse, slightly more psychological than
physical.
Yes, the physical. So that's grateful. I sort of felt I can get through this. Now there are a few more physical symptoms. I feel I can manage it, but should I? What would your advice be? Do you just manage it because there aren't that many and you kind of think you can get through it, or am I actually doing more harm than good to my body physically?
Yeah, so it's a great question, and in fact you're sitting behind my mother, who could probably answer no. She's behind. My mother's in front. No. You're sitting behind my mother, so therefore my mother is in front.
I need to take it, don't I?
You can maybe ask her what she thinks about taking HRT, but I'm putting her on the spot. But there are lots of benefits of taking HRT, and what's really interesting is that when you look at some of the guidelines, they say there isn't enough evidence for primary prevention of diseases such as cardiovascular disease. And that comes from America, because if they did say there was, they'd have to cover it on insurance. So it's a political games that they're playing. If you look at the evidence, there's more evidence that taking HRT reduces the risk of heart disease than taking a statin or a blood pressure lowering drug. So I think there's one thing about women suffering which drives me beyond distraction, but the other thing is if people aren't suffering at all, then we've got an evidence-based treatment that reduces the risk of number one killer, but we're not giving it to people. So if people have raised blood pressure, they often don't have symptoms, but we still treat them to reduce the risk of a heart disease or a heart attack or stroke. It's exactly the same. And so none of us know what's around the corner, of course. I'm not saying everyone's going to have heart disease, not everyone's going to have osteoporosis, but there is this increased inflammation that goes on as well. The other thing is, and I say to patients, I have no idea how many symptoms are related to menopause, perimenopause, or life, and there's often a combination. But what I can do is just restore hormones physiologically, because we are designed to have hormones, and see what's left. You know, if someone had an underactive thyroid gland, I wouldn't wait for them to be really, really bad. And it's the same with this. You don't get any medals for suffering, unfortunately, but you do have often a better quality of life by taking. But hormones are reversible. It's an informed choice. People can decide, and if they don't feel better, they can stop taking them.
And the risk to breast cancer?
So there isn't a risk with breast cancer with body-identical hormones. This WHI study that came out 20 years ago was using synthetic hormones, and actually what they did show, the combination estrogen and the synthetic progestogen, when they said to the media and to the medical press there was an increased risk, it wasn't statistically significant. And when they've unpicked the evidence, women who only had estrogen had a 23% lower risk of breast cancer and a lower risk of death of breast cancer by about 40%. The body-identical hormones have never shown this increased risk, and common sense will tell us that it hasn't as well. Even if you look at the worst studies showing the greatest risk, the way they skew the data, that risk is still lower than other risk factors for breast cancer, which include being overweight, not exercising, and drinking alcohol. 1 in 7 women will develop breast cancer whether they take HRT or not. So some women taking HRT will get breast cancer, but it's not due to their HRT. So we've got one more question, sorry. Yeah, I will be around at the end, so do you want to?
I wanted to flag up your 3 in 100, that it's younger women that get it, because although I got my cessation of periods at 47, both my daughters went into perimenopause and menopause at age 30, 31. And it was only discovered in one daughter because she was trying for a baby unsuccessfully and couldn't seem to create enough eggs because she'd basically almost run out. And then it was only a sort of, because I work in antenatal, and I flagged it that, is this okay and could we look at that area? In other words, anyone that's got a daughter needs to be aware of what not getting pregnant could mean. So that both my girls are on the full gamut, the trio of HRT and have been for nearly a decade. And thank goodness, because otherwise they'd be in for that big list.
Yeah.
And
no, it's really important. Some of you might have listened to podcasts that I've done with my 20-year-old daughter, who has some PMS. She uses patches actually to stabilise her hormones, and a lot of people don't want to have synthetic hormones, and the combination oral contraceptive and also progesterone only, basically giving people a chemical menopause because they're switching off their ovaries working, and will reduce testosterone as well. And so Kate Meals written a book which is coming out, which you all need to buy when it comes out, talking a lot about this actually. Because it is very important, and if we know that the average age of the menopause is 51, perimenopause symptoms can last for around 10 years. So women in their 40s by default will be menopausal or perimenopausal, but it means that a lot more women in their 30s will be perimenopausal. The 3 in 100, I think, is a lot more than that actually, and we know people living with HIV, it's about as high as 20 to 25%. Women in deprived areas, women on antidepressants often switch off their access, and so will reduce FSH and then reduce estradiol and testosterone, and also women with domestic abuse will reduce, women with trauma will reduce. We see a lot of women who've come from infertility clinics who've just not got quite enough hormones, so yeah, it's a lot more common, and we need to think about it, absolutely.
Thank you.
Thank you.